Hey, this is Andy,
And Randy.
and we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome back to another episode of AT Corner. For this education episode, we are doing a position statement series on acute wound care.
I thought that was a fill in the blank for a second.
Oh, I should have did a drum roll. We could make it up to you. What do you want to do?
Actually, I think the fill in the blank should be left to you.
Okay, fair.
You're the one who did the reading.
I did on acute wound care.
Okay, so what are our objectives for this?
Well, first, I'm pretty stoked that one, they even came out with a position statement on this, because I feel like wound care is like, it seems so arbitrary. Like everyone kind of like does their own thing.
Everyone does do their own thing.
Like something a little bit different. So I think
Yeah.
this is kind of cool. And I actually, I learned a good amount.
Soap and water.
Surprisingly, this position statement didn't really talk about soap.
Really?
Yeah, not that it's wrong. Please use soap and water. But it didn't really come up for how they laid out the position statement.
Okay, that's actually really fascinating because whenever I am sending my kids home, I just always tell them soap and water because I thought that was...
Oh, it is. It is the way to go. It's just how this one was laid out. I don't know. There wasn't an avenue to really talk about soap, which is weird when you talk about wound care.
Okay, so what are we talking about?
Yes, so we're going to discuss the position statement on the management of acute skin trauma. We'll review the wound healing process a little bit, and then we'll discuss the different supplies needed for appropriate wound care.
I think this is such a good topic to do in the winter because everyone's hands are cracked
Oh,
from
true.
washing their hands so much.
True, I didn't think about that.
Like little wounds, and then like getting into the new season, all the blisters. And
Well, also what we talked about in our last story episode with basketball, a lot of blood.
Lots of blood.
Apparently
Lots
that
of
was
blood.
the theme everyone talked about, was lots of blood.
Yeah, makes sense.
All right. So we can't talk about wound care without talking about the wound healing process. And luckily, if you've listened to probably 90% of our education episodes, the healing process for wounds is basically the same as soft tissues. So
Great.
not a huge extensive review, right? So you have your inflammatory phase, which also what we don't really talk about with some of the soft tissue injuries is that clotting cascade. So part of that inflammatory phase is that signal to tell the body like, hey, we're bleeding. We need to stop this blood. Let's create a clot, which is important in soft tissue injuries as well. But you don't really see the bleeding that often.
Right.
So you don't think about it. But obviously in wound care, there could be some blood. So the body has to turn that off. You don't want to be losing blood out there.
Unless you have a blood disorder and then it doesn't.
And then it doesn't do that very well.
Doesn't do that. Or if you take anti-inflammatory meds.
Yes, it
or
has.
blood thinners.
Yes. Shout out to warfarin. Brr, 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 brr.
Why shout out to warfarin?
I don't know, we're talking about blood thinners, so I was like, all right, let's do it. Obviously that's very important when we talk about wound healing. So that's one thing, that's one key aspect that we want to talk about with wound healing is the clotting cascade and how important it is for there.
That's actually what I talk about with my football players is to try to get them not to take ibuprofen.
Yes.
Before a game, especially for like the whole concussion thing.
Yeah.
I usually say, because I can go into the whole thing. One time I did, and one of my football players went away thinking that he was going to die.
That's what he told everybody. He said, well, Sandra says if I take this, I will die.
Which is absolutely no, I said. But that's how they do
Still
things.
effective.
That is. So now I just base it down to...
Dumb it down a bit.
No, I make it a little more basic. And I just say, I don't want you on a blood thinner while you're colliding into other people.
There you go.
Why don't you take Tylenol?
There you go. After the inflammatory phase, right, you have your proliferation phase. This is the signaling fibroblasts and everything else that's used for the formation of a scar. And then your maturation. Hey, we're going to shape that scar, make it a little bit better.
And that's also like the contracture where the wound gets all like wrinkly.
Oh yeah, and you start feeling a little tight around there.
Mm-hmm. I think that's really cool because it's like the body's trying to approximate the wound.
Yeah.
It's like its own steri strips.
Ooh, the body's own steri strips. How the position statement kind of define these acute wounds is you should expect them to heal within 4 to 6 weeks. Now, remember, that's also counting maturation process and all that stuff. Overall, the important thing that we need to know when we talk about the inflammatory process or the healing phases of a wound is our job when it comes to wound care and how we, clean and debride and cover and all this stuff is ideally we're just trying to optimize this process. We're trying to give it the best environment to help this wound heal. So everything that's talked about in this position statement is basically trying to make sure we're protecting the wound bed as much as possible and creating a nice environment for things to heal.
Which is why you should not use hydrogen peroxide.
Ooh,
did it talk about that?
Oh, yes, it did.
Yes,
and
okay.
we will get into that.
Okay.
All right.
We're coming for you, ATs who use that. I don't think.
Wow, that was aggressive. Oh my God. I mean, no judgments. If you do, here's the evidence.
Here's ATs. Here's why you should not do that.
In a non-aggressive way. So, now going into what this episode is about is the actual wound care process and what the position statement was going over. And essentially the position statement broke it down into kind of different categories. We went into the phases of essentially the cleansing process, the debridement process, the dressing process, and then the follow-up. So that's where we're going to start, because one of the first things you got to do with a wound is you got to clean it. You got to cleanse that. You should definitely clean it. So unfortunately with this episode and how the position statement is, it's going to be a little definition based just because you need to know what cleansing technically is to understand like how you're using it. And in the portion of cleansing, we're going to talk about like saline and pressures. And so it could get a little confusing. So that's why definitions will be important. It's the anatomy of this episode, I guess. So cleansing is the application of a non-toxic solution to aid in the removal of exudate, bacteria, foreign debris, and dressing residue to allow for an optimal environment for healing. Again, optimal. The key word in there besides the optimal environment is non-toxic, which again kind of hints toward peroxide.
Not your friend.
Not your friend.
Not inside the wound friend.
No, definitely not. One common technique that when you think of cleansing, most ATs will jump towards is irrigation. This is basically flowing some kind of solution over a wound bed. I know, very technical here. Essentially, this allows for the removal of debris and bacteria while preserving your healthy tissue.
Yeah, turf beads, gotta go.
Yes.
Rub some dirt in it.
Not good. No, don't do that. The turf beads part is actually going the next section for debridement.
Oh, I forgot.
Yes,
that was a step.
No,
okay.
They really split hairs in this position
Okay.
statement, because a part of it is, when we talk about cleansing or the debridement, right? A big thing is saline or water.
Right.
So they actually have recommendations for how much pressure is recommended for, like, if you're using saline.
Do you know how much pressure of water comes out of a Gatorade bottle or a Powerade bottle?
No. Do you?
No, but I think that is an important study that needs to be done. Because
it's almost like you read ahead because you're kind of reading my mind on some of this stuff. Okay. So again, when we think about cleansing and irrigation, the first thing everyone talks about is like probably water or saline.
Right.
And they actually do have pressure recommendations for when you're cleaning these wounds, right? Don't just like go out there and like get a power washer and blow up their skin, right? You're not trying to do that.
You don't want to make the wound bigger.
No. So it's recommended that you have about 4 to 15 PSI for cleansing most wounds.
Do you know what that is in real life?
Nope, I have no idea. But it is important because one of the easiest things is, actually I do know a little bit of what it would be in real life.
See, this is why I asked.
Yes. Like they do have those pressurized cans of saline.
Okay.
So it'd be cool. I've never really thought about looking into it. That's why I was really glad to dive into this position statement to see actually how much PSI that one shoots out water. Because if you really press it down, dude, that thing like aggressively shoots.
I love those things.
Me too. But now I'm interested. How much?
It doesn't say on it?
I'm sure it does, but I've never looked.
Okay. 4 through 15. We should look.
Yes.
4 to 15 is what we're supposed to do.
Anything less than 4 PSI, essentially all you're doing is just wetting the wound, which can be important, but if you're trying to cleanse, kind of defeats the purpose. So all you're doing is getting the wound wet. So a little bit more pressure is good. But also on the flip side, too much pressure could actually push bacteria into the wound bed.
I never thought about that.
I know, right? Isn't that insane? So don't go up there and trying to blast it. Again, not trying to make it worse.
I wonder, is it too much pressure just from a spray? Or what about pressure from like a gauze or...
They didn't talk about that. I think that's okay.
Okay.
I think that's
so
okay.
So like once you wrap it on like that.
Yeah.
Like, I mean, it's already clean.
Well, you already cleaned it. And then also on the flip side, the only other time you're adding pressure is to stop bleeding. So...
Yeah, well, what if you...
So I think...
What if you're out and someone's bleeding and you just apply pressure without cleaning the wound?
Well, I think at that point, the bleeding is the bigger concern. So that's kind of the most common one you think about, and is kind of good to know. Like, hey, you need some pressure, but you don't need a ton, and obviously not enough is just all you're doing is making the wound moist, which could be important, but again, defeats the cleansing process.
Mm-hmm.
There are other types of cleansing that the position statement goes into, which is very good information, but it's not as common within the athletic training practice. This is like something that I'm pretty sure you'd probably see in like chronic wounds or like a hospital setting, right? So showering,
wounds that are big enough that we're like, you know what, you should go.
Yes.
You should go.
Big time. Showering is one of them. Obviously, we've all had those athletes, it's like the game just ended. We're packing up, time to go. They're already going to go home and shower.
Yeah. So you hope.
Sorry. Theoretically, they should be going home and showering, or they have showers at the facility, depending on what setting you're at.
I actually have gotten enough people to tell me that they're not showering after the game, that if I give them an ACE wrap, I just tell them the next time you shower, take it off.
Yes.
Not, are you going to shower tonight? Because we don't need to go into that. No. You don't need to lie to me.
Please shower.
Yeah, right.
But, right, we've all sent those athletes soap and warm water in the shower, right? This kind of kept coming up in the position statement, but again, not really in the AT practice, is hydrotherapy. Using like a whirlpool.
For what? Like
wound cleaning and debridement.
Oh, because they say not to put wounds in the whirlpool.
Yeah, so but I guess there is, well, no, it is recommended in certain situations. But again, I think that's more of like a hospital setting when they can clean the whirlpool and like it's basically made to do that. I know, right? I didn't want to really talk about it because I don't want ATs out there thinking like, oh, I'm going to throw this in the whirlpool, which I don't think anyone would, but just in case.
I mean, a wound bucket.
A wound bucket, yeah. But they actually brought up a good point because of the whirlpool, the turbulent water, it basically creates that like flow across the wound bed to help clean the wound.
So,
but please do not send athletes into your whirlpool.
I'm just trying to. Oh well, I guess ultrasound is not supposed to be done over open wounds.
Yeah.
But what about like water ultrasound?
Ooh, they didn't talk about it.
I mean, not that I use
I would be interested on wound healing
because if you're talking
I'm sure
about,
there
like,
has
if you're
to be a
talking about
study.
like a current,
yeah,
and you have
we know ultrasound can affect fibroblasts
and help with wound healing. Yeah. Which I always was wondering about because I've never used it on a wound because you can't do it in an open wound. Yeah. So water wound?
That'd be, again, I think that'd be more of a hospital kind of chronic wound vibe. But hey, that's an interesting thought. Another type of cleansing that they talked about was scrubbing and swabbing. This is basically using like a gauze to remove bacteria. Like you're physically going in and like scraping this. That is definitely not recommended.
For at all or for
now
us?
Again, that's like at all, like
okay,
for
okay.
But it's important to note that we're talking about the cleansing section. This is literally cleaning the wound, not debridement.
Okay.
See, this is why it had to get technical.
Okay.
And then the next type that we talk about is obviously kind of using antiseptics. This is where we're going to knock hydrogen peroxide.
Okay.
So the most common ones that they talked about in the position statement were iodine and hydrogen peroxide. So can't really speak to like alcohol, which again is very aggressive and mean. If you're using alcohol, that's just mean.
Ow, yeah.
Yeah. But it's assumed it's in that same category, right? But obviously they didn't talk about like products like hand HIPAA so can't really speak to that necessarily. I've always known it as kind of it's good towards healthy tissue, but I'm not 100%.
Well, it's an antiseptic.
Yeah.
So.
But I can't remember if its formula is still good for healthy tissue. I can't remember. I've always been told that it was, but I can't remember.
I think it is.
Exactly. That's why I can't speak to it. So we're literally only talking about iodine and hydrogen peroxide.
Okay.
And that's what was listed in the position statement. And essentially their recommendation was it should be used with caution. Obviously, there's going to be times where it's
both of them?
Yes.
Interesting.
Obviously, there's going to be times where the risk of infection is a lot higher and you don't want the infection part. So you're kind of willing to risk some delayed healing to make sure there's no infection. But essentially, it delays healing because it can it's very toxic to healthy tissues.
Now, is this kind of like delay healing like people who are against ice, or is this delay healing like significant?
I would say it's pretty close. It's a good question. They didn't really give time frames.
Because here's the thing, is like we all understand that ice is not good long term for things, but you will probably never convince me that if one kid injures their ankle and is crying, I'm not going to give them an ice bag. Like, there's a time and a place for ice, and it's if that's beneficial for them at that moment. Yeah. If it delays their healing by a little bit, I'm not necessarily that worried about it. But is it the same thing as like hydrogen peroxide? I'm
not sure. I feel like it's a pretty significant delayed healing. Like I remember the ice thing, it's like a day.
Is it a full day?
I can't remember. I know it's like something like minuscule. Like it's like, all right. But I think the delayed healing with some of these antiseptics is kind of like, it's kind of notable. But also you have 4 to 6 weeks to heal most within that time frame to heal.
Right, which I guess you can also argue that is the wound really going to keep them from doing whatever
that too. Yeah. So
I guess we're not coming too hard for you.
But there's better options.
Right.
Whereas like kind of like some of the, like you said, in the situation where the kid's screaming, right? Like maybe ice is going to help with that pain when sometimes there's not suitable substitutes in that situation. Whereas wound healing,
you can choose cleansing, soap and water. You can choose, you can choose HIPAA.
Yeah. But what I did think was interesting in the position statement, they actually kind of gave a nice solution to someone who wants to use the antiseptic. Using diluted iodine is actually viable to preserve healthy tissue. And the formula that they had as a 1 to 10 mixture was effective in preventing infection.
You mean like water?
Yes.
Okay.
Was actually effective in preventing infection while also protecting human fibroblasts. So you still have good wound healing, but now you're helping prevent some infection. I thought that was very interesting.
Yeah, so is it talking about in the actual wound?
Yeah. So like how they did, I think that like you could do a syringe and like
kind of like
and wash it, because this is the cleansing part. So you're basically rinsing it.
I forgot we're still moving slow.
Yes, we're moving slow. We're on the basics here. But what was actually interesting is this dilution is kind of technical, because 1 to 5 was still toxic to fibroblasts.
So you can't eyeball it.
No, you should probably feel pretty good that's 1 to 10.
Dang. Okay, interesting.
Oh, also speaking of the syringe, you asked about like practical terms of pressure. Mm-hmm. They actually estimated that like a syringe, like just doing like if you were to rinse like saline over a wound with a syringe, that actually gives you the optimal pressure.
Okay, but
that was the practical portion of that.
Can you can push a syringe like real fast, or you can push it real slow?
I think it's just at a regular pace. Average. Like don't like, okay. Like you're not trying to go, ugh!
Okay.
Right? Like I think just you pressing to push it through is the optimal pressure.
Okay.
Yeah. So there is some practicalness too. It's not just arbitrary numbers, even though it kind of seems like it. All right, here's kind of like the downer news, which kind of complicates the cleansing process.
Okay.
The temperature of the cleansing agent could also matter. And the position statement recommends a temperature of 98.7, right? So body temperature,
Mm-hmm.
to 107 degrees Fahrenheit.
Okay.
Anything that cooler, like say you do something that's room temp, right? Anything like that cold can actually slow the activity of the cells within the wound bed. And what's crazy,
Okay.
what I thought this was crazy is it can actually take hours for these cells to regain their normal function. So here's the downside that I started thinking about to like normal clinical practice, right?
So like when we're out in the freaking cold and our things are in our bag.
One, when we're out in the freaking cold, right? So
You can't feel your fingers.
That's one, right? But also like a lot of times, like the saline can that you have, that's at room temp. And you just sit there and shh, unless obviously you're outside in the cold.
Yeah, actually,
right?
how do you get 98.7 degree saline?
Now again,
someone please, do you know those ultrasound warmers? It's like the
for saline. Could you imagine? It comes out piping hot.
They're like, oh my gosh!
But it is something to consider. Now, how much does that actually affect your wound healing process? I think it's minimal. I think it's I think if the choice,
if the game time was at 2 p.m., if my cells didn't take hours to regain normal function, then I would have been ready by 2 p.m. and not 5.
Well, also let's consider how many times have you been on like in an athletic environment, like the football field, or for the World Cup fans out there, the football field, and your wound wash was the Gatorade bottle.
That's what I'm
saying. Which is
saying.
Freezing cold because of the ice.
Those are cold.
Right?
Those are cold.
So, to be honest, I'm sure it's very minimal, and this is splitting hairs, but
it's in the position statement, so it matters.
And if you're trying to optimize wound healing, you do want to try and go with a warmer solution to help maintain our cells' activity.
This is just your fun party fact.
It really, I learned a lot, and I'm actually excited to try and work some of this into my wound care.
Well, I guess
to see if I can optimize it.
It's kind of like one of those things. It's like, okay, if we are really trying to optimize wound, like, oh, we need this wound to heal.
Yeah.
Let's try to get something body temperature versus cold.
Versus that cold Gatorade bottle.
Or if you're like, oh, you got a paper cut? Yeah, okay, it doesn't really matter that much.
Soap and warm
Even
water.
though they hurt.
Yes.
Even though they hurt.
So yeah, no, there's definitely some stuff that I thought was really interesting, and I'm really excited to try and implement this into my wound care management.
Good.
All right, so the next step, again, we had to split hairs, is now debridement. So now we're finally removing the ugly turf beads from this wound.
Oh, good. There was one wound this year that I had I was struggling to remove some turf beads, so I'm interested in this. So again, debridement is kind of broad, but it's essentially the removal of necrotic or devitalized tissue, microorganisms, contaminated tissue, fibrin, foreign bodies, and cellular debris from the wound bed. Essentially, you're removing crap from the wound bed. Now I have to make this explicit.
Yep. See what? No, I guarantee you no one else has explicit education out there. This is big time. I wish the position statement would have just summed it up as crap.
Yeah.
In the wound bed.
Yeah. Now, what do they say when it's like further? This will now be referenced as crap.
Yes, exactly. So I think it seems kind of obvious, but no one ever really talks about like, okay, when do you stop debriding? Even though you think it'd be obvious, but debridement occurs until you see normal vascularized tissue, which I thought was kind of good to know. Like, I'm sure someone has that question. It's like, okay, how do I know when to stop? And yeah, essentially you're just waiting to see that normal vascularized tissue. There are a couple of techniques, just like when we talked about cleansing. Again, a common one for debridement is irrigation. So, hey, you could probably kill 2 birds with 1 stone with using irrigation. The recommendations for debridement are the same as with cleansing. The pressure is the same. It's going to be about 4 to 15 psi. But what was interesting is there is an exception when it comes to puncture wounds.
Okay.
If you have a puncture wound, the recommended pressure is 2 to 4 psi because you don't want to push debris and other contaminants deeper into that wound.
So how do you cleanse it?
Just like 2 to 4 psi, so very light.
So that's legit. Like you can actually go lower than the cleansing recommendation for a puncture wound.
For a puncture wound. Now don't go in with like 15 and be like shh, because you're gonna push. You could push stuff deeper.
Don't do that.
Don't do that. Don't push stuff deeper. The next technique is a wet to dry technique. And what this is you use a pre-moistened gauze pad, you apply it to the wound bed, and then you let it sit there and dry. This could be up to 8 to 24 hours, and then you remove it. The idea behind this was, you remove unwanted debris as the gauze dried to the wound bed. But the problem is, this can also remove healthy tissue. And this was fun in my notes. I put, ouch.
No, that's so soft. He wrote all caps, ouch. Not recommended.
It is ouch. Right? Has anyone had a dried thing in their wound and then tried to remove it? It hurts because it's taking away healthy tissue. That's bad.
It is bad.
And
then you'll need to reread the wound care
position statement
so you know how to take care of it.
And again, the position statement was very clear. This is not recommended. Don't do this. Please don't do this.
So you don't want to do pre-moistened gauze.
No, that goes into the next one. Getting ahead of yourself.
Okay.
The next technique is wet to moist.
Well, why do they even write that as one of the techniques? Why don't they just put it as a do not?
Because I'm sure enough people do it that they're letting you know, hey, don't do this, please. Stop. Please stop. So the next one is kind of like what kind of going to give you the answer, is a wet to moist technique. This is similar to the wet to dry. You get a gauze pad, pre-moisten it, plop it on the wound bed. Please don't plop it, just place it, please. But this time, you don't let the gauze pad dry out. Mm-hmm. You remove it while it's still moist. This could be minutes, maybe a couple hours, but not the whole 8 to 24, right? This has the same idea. You could be removing some debris with it, but you're not taking healthy tissue. It minimizes that. It's much more comfortable. Again, I don't see too many people do it this way, placing a gauze pad and replacing it. I think this is more talking about not debris, like turf beads and stuff like that, but maybe right. Bad tissue or dying tissue that will stick to it, and then you remove it.
Okay. What about you have a gauze, a wet gauze.
Got my wet gauze.
You put it on the wound.
Okay.
You let it dry, and then you re-wet it to take it off.
So that will come up in the follow-up portion.
Okay.
But there are some dressings that if they do dry, to remove it, you should moisten it. And that will help remove it easier.
Right.
So yes.
Like blood stop.
Yes. That's what I would say. I'd say make sure you re-wet it before removing it. Because if it's too dry, you could be taking that healthy tissue.
Right.
So this is every athlete's favorite technique is the scrubbing aspect. When we talk about debris removal, which some of these turf beads, they get lodged in there.
They do.
And this is basically, again, this is a lot more technical than in the field, but it's the use of a sponge or a surgical scrub brush with saline or water. In our case, we kind of use gauze. They didn't bring it up in the scrubbing, so I don't know if that's bad or good, but obviously when you're in the field, you have to kind of do what you got to do.
I feel like we kind of have to do a poll on if you prefer woven gauze or non-woven gauze.
Ooh.
Because I just switched to non-woven.
Oh, it looks great.
Yeah, I don't know why.
I like the feel of it.
I don't know why we've ever used... I used to hate it, actually.
Big fan.
When I first saw it, I was like, what is this?
Big fan. Now, it does depend on the brand. Because some non-woven gauze brands are better than others.
Good to know.
Yeah.
I only found what was in my ATR, so...
So what I thought was interesting is...
It's still sterile, don't worry.
Yes. What I thought was interesting was, again, when we talk about wound care, I don't know, each program probably does a little bit different on how much time they actually spend. I feel like wound care is just kind of oh, it's wound care. They figure it out. You got it.
Yeah. Okay, this is how much I kind of, now that I'm certified for a couple years, I kind of assumed that was it's kind of come ingrained in me that I'm like, oh, that's a normal thing. But after I've had students, I'm like, oh, they don't know how to wound care.
Yeah,
oh, that's not common sense. That is something we have to teach. Okay, got it.
So there actually is a technique to actually scrubbing for debridement. And what the position statement brought up was you scour the wound bed basically from the middle of the wound bed to the edge in a circular pattern. I never knew that. I just would just try and like remove it.
I mean, I could see why.
Yeah.
It's like a reverse whirlpool.
Yeah. Just I never knew that.
No,
See?
I didn't know that either. I'm just
yeah.
telling you that
Yeah. See?
it makes sense.
Position statement coming in clutch.
Right.
And then the last one is kind of something we all kind of do is the sharp debridement. And this is essentially using sterile scissors, forceps, or tweezers to remove loosely adhering devitalized tissue that lies superficial to viable tissue on the wound bed. The first thing that comes to mind for me is blisters.
Mm-hmm.
If the skin flap is hanging and you're like, and this is useless, let's clean this up.
If it's crusty. Do they talk about like
not in depth? Now, everyone should know, by the way, is I'm sitting next to the blister specialist.
Not self-proclaimed.
No, but it was proclaimed by a very credible source.
My basketball coach.
That's right. The basketball coach has termed Sandra the blister specialist. I think we need an education episode from you just on blisters.
There is no degree to back that up.
But yeah, so that's essentially a sharp debridement. Again, it's just trying to get rid of all the useless crap or just dying tissue that could affect the healing and or it could make the injury worse. Like the same thing, like when you're talking about like the loose flap of a blister or like, some loose skin, right? If it catches, it could pull, tearing more skin.
Right.
So now you're trying to prevent more damage. So,
Well, it also depends on if you're in the phase that you're leaving it open or if you're covering it. Because if you're covering it, it's not really going to get caught on anything.
Yeah.
And that skin is going to help it heal.
Yeah.
But it depends.
Yeah, it does depend.
Sometimes when I'm dealing with blisters, I ask them how dirty their house is.
That's a good question.
Like, do we need to cover this for homework? Can I?
So, the vibe that I got from the position statement is wounds should be moist and covered most of the time.
You mean like from their beginning of existence?
Like what do you mean?
Do not let the wound dry out.
No, that's the vibe I got.
Okay.
I know. Everything they've talked about is letting the wound be moist.
Well, I mean that's like Neosporin.
Yeah. Now, not soaked. Please don't soak the wound.
Soak water or soak like Vaseline.
I don't know. Just like how like some people come in and it's just like overly wet.
Oh,
like
so you want a Goldilocks.
You want a Goldilocks. But no, that's what I thought was interesting too, because like some people feel that like, oh, like when it dries, you kind of want it to dry at this point. Now, once did a position statement bring that up, and it really talked about keeping the wound moist.
So I guess I do take care
Also,
of
I apologize for everyone who's listening that hates the word moist.
You interrupted me to say that.
Yes. Well, because I kept saying the word moist. And I felt like
you keep saying it now.
Well, I can't. I had to explain. I can't explain without saying it.
I was going to say,
Okay,
so I take care of my blisters differently than I take care of my wounds. But is that because I guess I don't really dry out my wounds.
Yeah.
I do dry out my blisters though, on purpose.
Yeah.
Did they talk about that?
Well, they lumped blisters in with all the wounds, so they just kind of counted it as a wound.
Well, I'll just still tell when we get to that point.
Yeah.
I'll.
Well, you're the blister specialist. I'm leaning towards you.
Okay. I didn't write a position statement. Or anything.
All right. So again, we gotta go to definitions. They talked about primary dressings and secondary dressings. So the primary dressing is the actual dressing that is touching the wound bed. It's literally the closest thing to the wound. And then the secondary basically covers the primary dressing. So there are different types. You have the non-occlusive, which this is like your gauze, non-adherent pads, adhesive strips, patches, so like Band-Aids. Mm-hmm. They can be used as primary dressings. This is especially when there's a quick return to play moment. Again, athletics. things have to happen pretty fast. You got to
Right,
cover
right.
it, get it back out there,
Mhm.
right? So they can be used, but from what I got from the position statement is it's probably better as a secondary dressing,
Mhm.
and it basically helps absorb any excessive discharge from the wound, or technically exudate. Discharge would be bad, or any leakage that could be coming from the wound as it goes through the primary dressing. And then the next type that they talked about was occlusive dressings. And this is why, like, I really enjoyed the position statement, because again, like when you talk about wound care, everyone just kind of like, here's a Band-Aid, right? And then they just
Yep.
kind of go on their way, or like, oh, you put a non-adherent pad, and like that's kind of it feels like. So it is really nice to kind of get this like in-depth information on, again, this is how you can really optimize how we treat wounds.
Mhm.
Your occlusive dressings are basically, I'm going to butcher this word, but elignates. Never heard of it. I'm going to butcher it. I knew it. But like your films, foams, hydrogels, hydrocolloids, etc. People probably don't know what those are. So some examples are like Polyskin 2. I've seen that before, or Bioclusive. Like I've seen those before. They're kind of like films
Mhm.
that you can put over the wound. Tegaderm. So those are some kind of examples of brands if you weren't sure what those like hydrogels and stuff were. Those are kind of like what would be called occlusive wounds. They really create a seal over that wound, protecting it and creating a good environment for it to heal. The position statement did a good job of kind of examining the literature between non-occlusive and occlusive dressings in terms of like wound healing, pain, and prevention. And essentially, occlusive dressings were superior to non-occlusive dressings, or no dressing at all, when it came to wound healing, pain, and preventing infection. So really, when we treat these wounds long-term, like if we're going for the long-term game, occlusive dressings are going to be your go-to.
Is it because it keeps the moisture in?
It can keep the moisture in. Some of these dressings, if the wound's really dry, it can actually help add moisture to it. So now it's again creating a better environment, and also because of the seal, it can help prevent infection. So not a lot of stuff's getting in. Whereas those non-occlusive dressings, right, like Band-Aid has a lot of gaps when you put it on.
Yeah.
Right. There's a lot of stuff that can get in there.
It's like a greenhouse for
yes.
your wound.
Yeah. It's essentially, yeah. And the nice thing with some of these films are you can actually still see the wound. So you can still observe and, see how it's looking. Whereas a Band-Aid can kind of cover it, and it's like a game of, what are we going to get when you take it off?
Right.
So
you want to know a trick to taking off occlusive dressings?
Go for it.
Okay, so I learned this from my co-head. Shout out Stephanie.
So
you
we need to add sound effects.
that sounds like a lot of work.
Okay, sorry to interrupt. Go ahead.
So let's say you have, I'm trying to figure out how to explain this. Top right corner. Okay, you're gonna, instead of peeling from the top right corner.
Okay.
And it doesn't matter what corner. I'm just picking a corner so you could, instead of peeling from the top right corner, you pull up and to the right, like in that diagonal.
Okay.
So you almost are stretching the dressing instead of peeling it.
Okay.
And because you're stretching it, it should naturally lift.
Oh, cool.
And it doesn't hurt as bad.
Yeah. Also, even the occlusive dressings, if it is like, obviously they can be on there for a long time. I think the position statement said like, as long as everything looks good, like there's no change, like the dressing's not starting to fall apart, or like, we'll talk about what to look for, or there's no signs of infection. Like basically everything's going good. Like occlusive dressings could be on for at least 7 days.
So does it not make your skin like that weird thing that Band-Aids do that makes your skin like all white and wrinkly? How does it not do that?
Good question. I've never been in a place that really had occlusive dressing, so I'm not sure.
Well, you probably are now, right?
I'm not sure.
Explain. You get to play around with them.
I do, hopefully.
I don't get it. I don't know.
Yeah, I'd be intrigued to know.
Maybe it's what's in them.
But again, that does go off of how does the wound look too.
So do they recommend occlusive dressings for blisters too?
Yes.
Interesting.
It was basically pretty much every wound.
I think I need to add that to my blister specialization.
I think you should.
Yeah.
Because, how it described is occlusive dressings were by far superior to the non-occlusive. But what I was going to say is when you're removing the occlusive dressing, that's what we want to look for too, is if it is sticking to the wound bed, obviously make it nice and wet, and then you can take it off so it doesn't take good tissue with it.
Yeah.
So after we got this bad boy dressed up, right? It's dressed to the nines, looking like $1,000,000. So I'm really going off of the dressing up part. Right? We always have our follow-up. Every AT's favorite thing, the follow-up.
How's it looking?
How's it looking? Right, we're going to look for any signs of infection. As a reminder, that's any pain, fever. By the way, if you have a fever from a wound, that's a problem.
Bad news.
That is
bad
systemic.
News. Yeah.
Warmth, edema, any redness, wound dehiscence. Dehiscence? Basically, if the wound is separating.
Okay.
Sorry, I knew I was going to butcher that word. Or any delayed wound healing. Any one of those could be a sign of infection. We're also going to check the quality of the dressing. So you're going to look to see, is there any leakage? Is there any strike through?
How come the signs of infection didn't talk about any like pus or discharge?
Discharge can be a sign of infection, but it also, there's sometimes you're going to get, like with some of these films, you'll see like a brownish fluid.
Okay, that's good to know.
And some people think that that's infection. That is not a sign of infection.
Okay.
Yeah. So maybe that's why. It basically was going over the general signs of infection.
Got it.
So yeah, you're going to look for how the quality of the dressing is. If there's any leakage, strike through, which is basically the exudate being present on the dressing, like it's starting to bleed through. Any channel formation, which is basically if the dressing is like starting to wrinkle, it creates these pathways from the wound bed to the edge of the dressing, which is bad because, right, it's creating an exposure.
Oh, right.
Any of those signs may warrant you changing the dressing. So adding a new one or anything like that. And then you're also going to check for a dressing transition. As a wound heals, it might transition to different dressings. Some of this does depend on the moisture of the wound, right? If the wound's starting to get really dry, you might need a dressing that kind of helps, make it a little more moist. If it's already moist, then hey, you just need something to maintain that environment. You don't need to like overly saturate it. And like I said, important when you're removing dressings, it might need to be moistened before you just remove it. It's not, when people talk about like the Band-Aid ripping it off, maybe that's not a great idea. Depending. Now, obviously, like the whole, like, if it's sticking to your hairs, okay, you got to kind of toughen up, even though I'm not going to toughen up. But if it's sticking to the wound, no. We don't need to rip that Band-Aid off.
Well, yeah, because then you're just going to have to do the process
over again. All right.
Now I'm going to talk about my blisters.
Yeah, go for it.
Oh, or are you going to say something?
Oh, I was going to throw in an action item.
Oh, I was going to remind you of that
That's
too.
right, because I
was going to wait till the end, so.
Oh, okay. Well, that's all I have. Go for it.
Okay,
let's talk about your blisters.
We can't forget the action item. Though.
Okay, we probably will.
No.
We have a few times.
we have. All
right,
because we don't write it. Okay, so for blisters, and I think the reason why I do this is mostly because of the flap on top.
Yeah.
Okay, so if it has a flap on top, well, first of all, if it's a blister with like liquid in it, I keep it unless it's in an area, well, it probably is an area that it's going to pop by itself. And I would rather have a controlled pop than a random
uncontrolled pop.
Right?
Yes. I get what you're saying. I'm picking up what you're putting down.
So whichever way that your
controlled pop,
your state allows you to do a controlled pop, that I will not put myself
or drainage.
Right.
Maybe pops about drainage.
Right. So you're going to pop it controlled. And then I want to dry out that top layer. And I know, so some people do like what's that sticky stick
Oh,
it,
yeah.
stick it.
Yeah.
Some people put it in there and it burns really bad. I don't do that, but it basically that helps because it prevents because you're dealing with a friction injury.
Yes.
So you're just trying to prevent friction.
Yes.
So what I do is I try to stop the or I try to allow it to heal by putting zinc oxide on that top layer, because that top layer is going to dry out. And then once that top layer dries out, then you can remove it.
Yeah.
But you want to keep it on to keep that moist environment inside.
Yes.
So I'm technically not actually doing zinc oxide. I'm not like actually drying out the wound itself.
You're trying to dry out the top part.
Drying out the top layer.
Yeah.
I guess that is important to differentiate.
Yeah.
So anyway, I do that, and then because it's still gonna move, there's a couple different ways that you can stop that friction. So either you can do like a second skin if they need some padding on it, or you can do with cover roll. You can do a donut. Sometimes I do leukotape. And the reason why is because it's essentially creating a second layer.
Okay.
That now should not hurt, because the thing that hurts is that skin moving.
Yeah.
But with the leukotape,
not much is moving.
It's not moving.
That's true. Interesting.
So if it's not painful to the touch, that could be a good way to get that friction to stop.
Interesting.
That's also a good way to prevent blisters, is to just put a layer of leukotape.
Yeah, that's true.
Or cover roll. But cover roll tends to move a little bit more, so yeah. I tend to go to leukotape. But leukotape's also my favorite tape, so I'm a little biased.
I love leukotape. I love it.
And then once that top layer is dry, then you want to keep it moist for that friction. So you can do like a triple antibiotic, or you can do a simple heel and lace pad, or just something to add to that moisture. Yeah. And then you're good to go.
Nice.
So dry out first. Take it off.
Blister specialist right
here. Keep it moist.
Keep it wound. Yeah, keep it wound.
Keep it wound. That's your action item. Keep it wound. What do you do?
For my blisters?
Yeah.
I just kind of treat it like every other wound. If the skin flap is still somewhat intact, I'll keep it.
And if it's folded, you have to put the skin flap. You have to flatten it.
Yeah.
That's something I see too.
If it looks pretty useless and it's just kind of there, I'll trim it off.
Like if the wound is not ready yet, or do you wait till there's like skin?
Yeah, I mean,
I always wait.
Yeah, if it's just there and it's not serving a purpose anymore, I'll take it off. I'll trim it. The wound bed should be fine as long as it's, as long as you follow the position statement and, do all these things. So it should be fine. I'm just worried, if it catches on something, it could tear, create more pain and discomfort. So if it looks pretty useless, I just take it off. But yeah, second skin. I've had a lot of people who need more than the second skin. Like I've had some people where it's in such a difficult spot that I've had to do donut pads.
Last year I had someone with the entire ball of their foot on both feet.
Oh, that's brutal.
That's what gave me my name.
That's brutal.
Yeah.
What about those deep ones where there's actually skin over the blister? That one's a bummer.
Oof, yeah. That's when you have to like yeah.
That one's a bummer.
Oh, that also reminds me of so in the drying out phase, I try to have them keep it open as much as possible in like at home in their like if their environment, like not if they're walking around the house.
Yeah.
But like in their own room or like somewhere that's like cleaner.
Yeah.
I mean, not that their room's clean, but I mean like it's their own germs, hopefully. Rather than just like actual dirt tracked in from the outside or something. Yeah. So I try to keep that so the top layer dries out faster. And then once that is, then I keep it moist the entire time.
Got it.
So that's where I got the like dry it
Yeah.
out first and then.
Yeah, got it. Nice.
Yeah. Did you do your action item?
No,
You want to do the action item?
yeah, let's do it. Clean the wound. Again, antiseptics probably aren't the best, but still have a place. So use your judgment. And occlusive dressings are better, apparently. So it's something to look into if you're really trying to optimize wound healing. Again, just because you use a non-occlusive dressing does not mean you did it wrong. You know, there are times and places for them, especially, right? Like, I'm not going to tell coach, sorry, hold on, coach. I got to take care of this wound real quick. You know, I got to do this, right? There's going to be times you're going to do real quick and then, hey, here's a non-occlusive, get out there.
I'm going to take care of your paper cut like I would a huge 4-inch turf burn.
Yeah, exactly, right? Time and place, but remember, for long-term management, your occlusive dressings are going to be your bread and butter. That's going to be the best way to manage any wound that you get. And also, keep observing the wound. Make sure it's healing well. Make sure there's no signs of infection.
Okay, I know we usually do action item at the end, but I actually do have a question that just popped up in my brain.
Let's do it.
So for stitches, when someone gets stitches,
Yes.
I feel like usually those are just out in the open.
Yeah.
Did they say anything about covering those?
Yeah, they talked about, like, not in depth, but they still talked about a non-occlusive dressing.
Not an
Or, I'm sorry, not occlusive dressing. Sorry. That can be used for that.
Occlusive dressing over stitches?
Yeah.
Interesting.
I know. I haven't seen it, so that's why I'm like,
I haven't either.
I'm hesitant, but they did talk about that, so
Wait, wouldn't
it can
you like
help.
pull on the stitches when you take it off? Is that why?
yeah, I think it'd be okay.
Hmm.
But again, that's kind of up to the doctor.
Non-adherent pad and then occlusive dressing.
I'd also kind of keep it up to the doctor's choice, because they also have, like, after surgery they have those wound healing like checklists or like information sheets, which, I mean, hospitals and like doctors' offices, like they're pretty on point when it comes to wound healing. So I'd kind of defer to that. But from what I got from the position statement, it seemed like it'd be all right.
Yeah. Okay.
Yeah.
Good to know.
Yeah. Good to know. That's what I thought.
Cool. Well, if you guys want to look at the references for this, I believe there's just one, right?
Yeah. So I don't think there'll be
position statements. We usually just do the one.
So it's just the NATA position statement on acute wound management.
If you want to be part of our poll, we're putting it on our Facebook group, facebook.com/group/AT Corner Podcast.
Is that the question of the week?
We said it earlier.
Okay. So we'll do the poll.
Yeah.
Doing the poll.
Maybe we'll do 2 questions a week. We'll see. Oh, we're doing 2 episodes this week, so I don't know.
Maybe.
Well,
We'll
maybe.
see.
We'll see.
You know what? We're really just shooting from the hip in this episode.
We are.
This week's a little crazy because of Thanksgiving. It's all the tryptophan.
If you guys are new, we do every other episode as education or stories. This one was hopefully, obviously, an education story.
I learned a lot.
And it's an education story. It's an education episode. Next week we are going back to. Actually, this week we are going back to our episode, our stories.
The second episode of the week will be a story one.
It's a huge topic. We're talking about mental health, and not just mental health of our athletes, but also mental health of ATs.
Ooh, that's a good one. No one talks about that.
Yeah,
no one talks. All we talk about is burnout, which has obviously mental health components,
right?
But no one talks about mental health within the clinician.
Working with mental health. So we're gonna so stay tuned for that. If you guys want to get CEUs for this episode, we did not talk about that. We should probably talk about that.
Yeah, that's a big deal.
So CEUs for this episode, if you're listening to this actively and this is the latest episode, it is free.
Woo!
If it is within the latest 3 after that, then it is $1.
Which is pretty good for CEUs. Just saying.
Yeah, that is really good. So super thank you to Precision AT for still honoring that. Those free CEUs. And $1 CEUs, which is also a really legit.
that is a big thanks to Precision AT. They do a lot of work for us on that end. So we really do. We do appreciate everything that they do and help. And helping us offer CEUs to begin with. So that's awesome.
Right. And then lastly, anything beyond our latest 4, I believe,
Yes,
is just regularly priced, and
Yes.
and those proceeds will go to both our partner and ourselves.
Yes.
So you will help support the show.
It is supporting the show.
It is. It does. So. And lastly, if you guys are still looking for some more CEUs, we have that partnership with MedBridge. We are doing a Black Friday special before the 30th, so make sure it's the last couple of days that you can use it. But we are doing 13 months for the price of 12.
Ooh.
So you can just use code ATcorner13. And if you're not listening to this before that, you can still do MedBridge. We have $150 off. Just use code ATcorner. There's a whole bunch of more fun stuff down in the show notes, so make sure you scroll down. And I think that's all of our final.
Yeah, hey, the CEU deadline's coming.
It is.
And we're almost into the reporting year.
Mm-hmm.
So, hey, now's the time to catch up. And also don't forget the BOC fee.
Oh, yeah. Don't forget that.
That's in the end of December this year.
All right.
There's a lot going on.
There is. We will hear from you very soon. Or you will hear from us in 2 days.
Yeah, actually, yes, that's true. We will have another episode this week.
All right.
All right. Thank you for helping us showcase athlete training behind the tape. Bye.